before they start, and then I'm also going to facilitate the Q&A. If you want to ask questions, feel free to put some in the chat and I can monitor it towards the end. I could also, I'm going to seed a few questions myself, but I want to thank Dr. Hébert and Mayank very much for joining us today. And I see we have gone past the 20 mark, so we are ready to get started. So again, welcome to Implementation Science in a Global Context. We're going to have future webinars, and so feel free to respond to our short evaluation question at the end and give us ideas for future webinars as well. So we're going to start first with Dr. James Hébert from the South Carolina CPCRN, and also our second speaker is Mayank Sakhuja, also from South Carolina. He is a CPCRN alum, first and foremost, but he's also a doctoral student at USC. So I'm going to start and introduce somebody that probably doesn't need to have any introductions. I have enjoyed working with Dr. Hébert in CPCRN as a colleague and as a co-PI for a long time. He is a health sciences distinguished professor of epidemiology in the Arnold School of Public Health at USC. He's been the director of the CPCRN, the Cancer Prevention and Control Program statewide since its founding in 2003. He did both his MSPH in environmental health from University of Washington and his science doctorate SCD in nutritional epidemiology from Harvard University. He has done a lot of work internationally. He's conducted research projects in India, South Asia, and East Africa. And he has been working on past Fulbrights and also a scholar with a lot of different collaborators. He's done dietary, nutritional, and dietary assessment in terms of creating dietary inflammatory indices related to different chronic diseases such as diabetes, depression, cardiovascular disease, and cancer, among other things. And we are delighted to learn about his cross-cultural experience. I have heard about some in my CPCRN life with him, and we're excited to learn about how his D&I research in that global setting can help make effective and sustainable changes to improve global public health. So, James, I'm going to turn it over to you.
Okay, sounds good. And I'm going to go ahead and share my screen, which presumably everybody can see now. Correct?
Yes.
Perfect. Okay. So I'm not going to reintroduce myself. Cam did a great job of introducing me. The one thing I'd like to notice, you'll see CPCRN is the center of this slide. So this occupies an important part in my life. And I also wanted to mention that we also have this company called Connecting Health Innovations, which grew out of much of this work. And we just published this book recently on diet, inflammation, and health. So here are my disclosures. I'm not going to read them to you. I think the most important one but most important too for the purposes of this talk is I'm an epidemiologist. I'm not a behaviorist or a health promotionist. I don't know that that's a word, but I'm not that. And I'm pretty comfortable admitting that I don't know certain things. So as I've gotten older, I've become way more comfortable with not knowing things. When I was younger, it really bothered me a lot. I was inquisitive, but I don't have a lot of emotional attachment to not knowing stuff. So I think that's important to keep in mind. And it's really, I'm going to talk about my journey. This is going to be a travelogue. I'm not going to give you a lot of data. I'm going to tell you basically a story. And the story starts for me, like most people's story, pretty early in life. So I grew up in the Connecticut Valley. My family's originally from Quebec, but I grew up in the States. And this is a shot near the place where I grew up. And this is the Connecticut Valley is very lush. It's very beautiful. It's basically glacial till. So if you look at Long Island and Martha's Vineyard and Cape Cod, they're the terminal moraine of the last glacier that covered North America. So this is an area that has really rich soil, and we had a really big, very nice garden. Huge, as my brother would say, an industrial scale garden. So we grew a lot of food. This is an area of the country where there's also shade-grown tobacco. So basically, the tobacco industry exploited the natural fertility of the soil here in really pernicious ways. So I don't know how many of you are familiar with growing tobacco, but it's the second heaviest feeding crop. It just draws nitrogen out of the soil like crazy. So I grew up with those two realities there, and it was very formative. But I didn't really have a sense of how complicated the food picture would be. So when I went off to college, my repertoire got a lot bigger in a lot of ways. I started out in biomedical engineering, and I switched to biology. And then it took me a long time to get to graduate school, many years. Students talk about a gap year. I took a gap decade, just about. So that's an important part of my story, because I use this time to do interesting things like travel around the world. So I owned a construction company in Colorado. I sold it and then went off with my then girlfriend on what was then the hippie trail. No longer exists. You can look it up. You can go on the internet, type in hippie trail. And after 2 months of hitchhiking and taking third class transportation across Europe, I wind up in Afghanistan, and it was like being shot out of a cannon into the past. So I'd never seen anything like this. My life until this point had existed of, North America, visiting relatives in Quebec and living in Colorado, and ultimately would be Washington State as well. But I'd never seen anything like this. This was just unbelievable to me. And I knew I was going to public health school. I applied to school before this trip. So I had gotten into a bunch of different places. I hadn't quite decided where I was going to be, but this was an important part of my experience. And I would interview people everywhere I went. I would find out people were running water supply systems and clinics and stuff like that, and I would connect with them. And I kept a really nice notebook. So I had lots and lots of notes from those days. I broke a lot of teeth when I was in Afghanistan because the food was delicious, but there would be these little rocks in there, which is kind of, I didn't have that experience. So the landscape here was just so different. So, I mean, this is before I got to India. My trip outside of the US, outside of North America, started in Europe and then went on the hippie trail to India, basically, and ultimately to Nepal. So this is a place called Bandi Amir, which is just gorgeous, and it's in east central Afghanistan. And here's the Buddha, the Buddha at Bamiyan, and it was built in 544 AD, and it was destroyed by the Taliban about 1,500 years later. And I actually climbed up to the top of Buddha here, which is nice. It was a really great experience. So I go over the Khyber Pass, and I wound up in a place called Ranthambore, which is in Rajasthan. And again, the topography was very different to what I'd seen, and I had become familiar with Indian food at this point. So I was familiar with that, and I insisted we go here. It wasn't officially in the travel brochures, and I told Deborah I wanted to go there, and I was going to go back to Afghanistan unless we could go there. She said, it's not in the travel brochure. I said, but it's in the 1973 travel brochure. So she said, okay, we'll just go there. So we went to Ranthambore, which is just an amazing place. It's a Project Tiger Park. And again, I was very interested in public health. I was interviewing people in the area, and this was I could talk, each one of these slides could lead me onto a different talk, but we want to get to Mayank. So I want to keep the story moving along, but this is a remarkable place that tuned me in to just how different the topography was and what other things would be required to live there, including religious issues and sociocultural issues. And that's a really important part of this. The connections that I made with people were because based on my true curiosity about what was going on in terms of Hindu beliefs and Muslim beliefs and so forth. This is a guy by the name of Lochan Vishal Sharma, who I met in Jodhpur, which was not too far from Ranthambore, it's a little bit north of there. So he was sannyasin. He was the guy who had lived as a civil servant. He was a mathematical genius. He knew about 5 languages, and he was a really fun-loving character. And he lived on the top of this hill by this cenotaph and took care of crazy people and animals. So I spent a couple of weeks with him. And this is a shot. I had a very bad road accident in Rishikesh. And this is a scene from Rishikesh. This is a place called Chotiwala, where you could get unbelievably delicious vegetarian food. Remember, I'm interested in nutrition. Don't forget that. That's an important part of this story. So we were eating meals here for like 50 paisa a day, which, I mean, in those days, the rupee was trading 7 to the dollar. So it was, cheap. It was like, 10 to 15 cents for a meal. And it was just amazing. And I did therapy there. I got a lot of massage from people. And again, asking questions about, how people live and where does the food come from and how it's grown and so forth. And one of the things that I learned in all of this, Gandhi had been one of my heroes. I got interested in the civil rights movement. And I knew that Martin Luther King, though he had never met Gandhi, patterned the civil disobedience in the US after what was going on in India. And he did meet his family, but he never actually met Gandhi. Gandhi understood a really important thing about colonialism, and that is one of the ways that colonial powers stay in power is they disrupt the normal means of production. So that's why Gandhi was always at the spinning wheel. People think, well, that was just some really weird idiosyncrasy of Gandhi. But no, it was very purposeful. He understood the connection between local production of textiles and food production. And he really firmly believed that in order for India to become independent of England, they had to overcome this problem. So he was very dedicated to doing this. And these are a couple of women that I met along, my young girls, actually, they're in their teens. And this is a picture of them and their home loom at home. So they're doing this, they're making these textiles at home and they're growing their own food. So again, it's connecting the means of production with the both food and non-food crops with other production, like textiles, for example. And one of the things I got very interested in India, because the climate patterns were so much different to what I was used to in North America. So the monsoon would come in like clockwork. I mean, Mayank knows this. He's from Maharashtra. Unless the monsoon fails, the monsoon will show up in Mumbai on June 15th. And so this is the advancing monsoon. And I lived in the south of India. I spent 2 years doing my project work there, and they would get the retreating monsoon. And what I found interesting, because I knew about these big Indian famines, but I didn't understand very much about what was the cause of them. So I did a lot of work when I was in India looking at weather patterns. And I looked for a period of about 150 years through the period of great famines in India, and there was basically no relationship at all. So I wrote this article based on my experience in India, and then spending time in the Harvard Library, the Widener Library, where I could read the actual famine documents. So by the time I met Prakash Gupta, don't worry, Mayank, I will connect it to Prakash. By the time I met Prakash in the late 1980s, when my daughter was born, so he's known me the entire life of my daughter, so about 35 years now. I had already gotten really familiar with this, and I was living in the south of India, and he's from I guess you'd call Maharashtra. I guess if you're in the South, you call it North India. You know, it's like Northern California is anything north of Big Sur if you're in California. But I was familiar with this stuff, and I understood how important religion was in all of this for a variety of reasons. So with this in mind, I then worked with UNICEF for a couple of years in Karamoja, which is a part of Uganda. It's a very arid area on the Kenya border. And south of Sudan. So the Dinka live to the north, and the Karamojong live in Karamoja. And what's the tribe? I'm forgetting the name of the tribe in Kenya. They're very famous too. Very tall people, pastoralists, and so forth. So I'm working with this group of people, and I have that experience. So I'm now doing implementation of the work that I was interested in focusing on famine. So I'm hired by the UN to do this work. And this is a picture of Manyata in Karamoja. This is a very densely populated part of it. I mean, Karamoja is the size of Connecticut, and it's got about, at the height, maybe 100,000 people in it. So it's very sparsely populated. But I'm applying the work that I started doing in India that got into policy in Africa, where we're feeding kids and helping to prevent a lot of starvation. The infant mortality rate in this area of the country was over 600 per thousand live births. So this is the highest infant mortality rate ever reported on planet Earth. I then want to reflect a little bit on my time in India. So I did that field work, and one of the places that I like to go was the Theosophical Society. The Theosophical Society is very interesting because it brings all the religions of the world together in one place. So India's, with the exception of the current BJP Modi business that's going on right now, has been a very welcoming country. So when the Spanish Inquisition happened, many of the Jews that were in Europe wound up going to the west coast of India. So the Theosophical Society was just north of where I worked. So my field work was done in these fishing villages, which were in the southern part of Madras. And I like taking pictures of kids. So these are some of the kids that I worked with in those days. So these are Patinavar kids. They're part of this Jati, this fisherman group. And again, I'm doing my nutritional epidemiology, but also working with the corporation to get people water. The kids who lived on this side of the road near the sea did much better than the ones that were on the other side of the road. So they were using the seawater for washing, but the water supply was terrible. So I got very involved because remember, I had started out as an engineer originally and doing environmental health. So I was bringing these things together in a very practical way, trying to help people live their lives in a better way. And this is a reminder that if you look at the temple systems throughout India, but this is a picture from Tamil Nadu, where I used to live, they're accompanied with temple tanks. This temple's from about 700 AD, so it's significantly degraded in terms of the surroundings. But the temple would provide resources to people that were buffer against famine. So one of the things that happened, especially in this part of India where the Riot Wari was in force, the way of organizing land tenure, is there were very few famines, which was a really important thing to keep in mind. This is just a shot of the food that's grown there and eaten. This is a South Indian thali. And then when I went back for my second sabbatical, I spent half the time in Belapur with Prakash Gupta, and the other half of the time at Tata Memorial. This was the site in India where the biggest cancer hospital had its bone marrow transplantation unit. And I thought this would be interesting to show. Typically, and Mayank and other people who have been to India know this, when you go to the hospital, you don't go alone. You go with your family. So these are the bone marrow transplantation unit would keep people there for, literally weeks at a time, and the families would just be there. And I go around and chat them up. They'd be coming from Orissa, from all states all over India. A lot were from Russia, but a lot were from other places as well. So this is just a picture of Prakash, myself, and Gloria Sorensen, whom I introduced to Prakash. She's now retired, but she was my counterpart at Harvard for many years. And here we are with where Prakash's work. Prakash, like me, is an epidemiologist, but he's more famous now for his tobacco control work. So I wanted to show a picture of us at the main hospital in Parel in Mumbai, which is across the waterway from Navi Mumbai, where the ACTREC was located. And I'm almost done. So this is a shot of, which I'm sure Mayank can relate to. This is a shot of Prakash in his office at Healis. And my host for most of what I did working in the early years with Prakash was done with Ramesh Bhosle, he's like a saint, and many of the people that I encountered were that way. And so many years later, when I heard of Mayank's interest, I introduced Mayank to Prakash, and now you're going to hear Mayank's story, and I'm going to stop sharing my screen.
Thank you so much, James. I love your travel montage, your amazing pictures, and I think you probably infused global climate awareness in your work, which was a great thing to see in terms of public health, in terms of the nutrition work. So I know there'll be other questions, but I'm going to turn it over to Mayank Sakhuja. Mayank is a fourth-year doctoral candidate in the Department of Health Promotion, Education and Behavior at the Arnold School of Public Health at USC. He was born and raised in India, and his undergraduate was in business economics, and he's a graduate in health administration. We won't hold that against you. He works as a GRA with Dr. Friedman here, one of our scholars co-leads, and he focuses his work on cancer prevention control, health communication, and health literacy. His dissertation work is sponsored by the Institute for Global Tobacco Control at the Johns Hopkins Bloomberg School of Public Health, and he is integrating his research to inform cancer prevention policies and communication with a big emphasis on tobacco control. He's interested in policy and communication issues around tobacco promotion and advertising at the point of sales. Also health warning labels on tobacco products, smoking and tobacco cessation, and the sales and purchase of tobacco products. I'm going to turn it over to Mayank for his presentation.
Thank you, Dr. Escoffery and Dr. Friedman, for this opportunity to present alongside Dr. Hébert. Dr. Hébert, that was a great presentation. I felt you know India better than me. And I'll just start right away with my slides. So I'll be presenting one of my dissertation components, which is a stakeholder analysis to understand facilitators and barriers to implementation of a tobacco control policy in India. And just to start with, just wanted to give everyone a brief background about the different kinds of tobacco products that are available in India. And they can be categorized into smokeless tobacco, such as pan masala, which are consumed orally. Then there are smoked tobacco products like cigarettes and BDs, which most of us are familiar with. And then there are emerging products such as hookahs, or you can call it water pipe hookahs, and e-cigarettes and vapes, which are now very emerging and very common among the young generations. Some pictures for you all. So these are the different kinds of smokeless tobacco products that are commonly used in India, and they are quite widespread especially in the rural neighborhoods. And this is what is inside them. It's basically consumed by mixing, as you can see in the left image, it's a broken betel nut or areca nut, and then it is mixed with crushed tobacco leaves and then consumed orally. And this is a picture from my field visit, and it shows the emerging products that are available in India, like such as the hookah, which is on the top shelf over here, and below are some flavors that are used with that device. And the most common smoked tobacco products in India are cigarettes, as you can see here, and BDs. The left one are legally sold in India because they have a health warnings on them, pictorial graphics on them, whereas the cigarette pack on the right is illegally sold because it doesn't have any health warnings, and it's mandatory uh, to have pictorial health warnings on cigarette packs in India. And this is the other most commonly used smoked tobacco product, BD. Uh, BD is manufactured in like a very unregulated settings, and they are just crushed tobacco leaves which are wrapped inside another kind of leaf and then tied with a thread. So now the question is, what is the problem? The problem that I'm focusing on through my dissertation work is the sale of these smoked tobacco products, cigarettes and BDs in loose, which means you can visit a tobacco vendor and you can just ask for an individual stick. You do not have to purchase the whole pack, which is the rule in countries like the US. You cannot go and purchase a single stick. And so why that is a problem? It's a problem because it provides easy access to youths, to younger kids. This was a picture that I took from my field work in India, and this child was selling tobacco products, and I was just wondering if the seller is himself an underage kid, how that would stop selling tobacco products to other underage consumers. So the problem is that if loose cigarettes are and loose BDs are easily available, it provides easy access to underage kids and minority population. Then the problem is also associated with smoking in public places. If a consumer is purchasing loose cigarettes or loose BDs, he won't carry it them with at his or her place, at his or her home. He'll end up smoking in a public setting, in an outdoor setting, leading to secondhand smoke exposures. And finally, it potentially reduces your exposure to health warning labels, as it is mandatory in India to have health warnings or pictorial warnings on cigarette packs. And if consumers are purchasing loose cigarettes, that significantly reduces their exposure to those pictorial warnings. So the FCTC is a treaty. It's a public health treaty that addresses tobacco control issues in India, and it recommends several demand and supply reduction measures to reduce tobacco prevalence. And one of the articles of the WHO FCTC states that it emphasizes on the importance of prohibiting the sale of cigarettes individually or in small packets, which increase the affordability of such product to minors. So what's the possible solution? And one of the possible solution is to have a ban on the sale of loose tobacco products, which is the focus of my one of my dissertation. So just to give you a brief background about the situation of current laws around the loose sale of tobacco products in India. In 2015, there was this amendment which stated that no person shall sell or offer for sale or permit sale of cigarettes or any other tobacco products in loose. And because of that amendment, a few Indian states, such as Maharashtra, which Dr. Hébert mentioned in his presentation, so Maharashtra was the first state to ban the sale of loose cigarettes and loose BDs in 2020. And currently, there are many states in India with high smoking prevalence who are yet to implement the ban. And recently, in December 2022, the Parliament Standing Committee on Health recommended the government to ban the sale of loose sticks of cigarettes and BDs. And this recommendation is still pending for approval by the central government. So the few policy implementation research questions that I had considered were like, will this policy ban be effective? And what will be the barriers in the implementation process? And what will be the facilitators for effective policy implementation? And to answer all these questions, there was a need for a stakeholder analysis, because one of the important components of in implementation science research is to assess what different stakeholders perceive about the intervention or the policy in consideration. And now it's important to identify who are those who have an interest in the issue, and who may be affected by the issue, or who could have a possible influence in the implementation of the policy. And we identified that the main stakeholders involved in this policy implementation were smokers themselves, the people who smoke cigarettes or BDs, and then vendors, like those who sell tobacco products, and finally people who enforce tobacco control provisions, which include policymakers, implementers, and law enforcement officials. So Dr. Hébert then introduced me to Prakash Gupta at Healis, and with their help, using an iterative approach, I developed 3 interview guides for qualitative interviews, and I used the framework by Belaine. And the reason why I used their framework was because it could be applied to policy implementation research, and this framework was field tested in a low and middle income country. And then the interview questions were based on these 4 constructs: knowledge, which assessed stakeholders' knowledge and understanding of the policy; interest, which aimed to assess stakeholders' motivation and perceived impact of the policy implementation to their own organization; power, which assess what are the different kinds of power, what are the different abilities that the stakeholders have in policy implementation; and finally position, whether the stakeholders supported or they opposed, or were they neutral about this policy regarding banning the sale of loose cigarettes. So we selected 2 most populous cities in India, Delhi and Mumbai. Mumbai was selected because there is a ban on sale of loose cigarettes in Mumbai since 2020, and Delhi was selected because the ban is yet to be implemented in this city. And the purpose of this stakeholder evaluation was not only to evaluate the policy ban in existing cities, in existing states, but also to use the findings from this work and share these findings for further scaling up of this policy implementation in other cities. So I followed a walk. I did an extensive field work in India for 4 months, and I followed a walking and recruitment protocol where I identified prominent locations in the cities, and then followed a walking protocol to identify places where commercial activities were taking place. And after recruiting cigarette vendors, and after recruiting these tobacco vendors and cigarette smokers, and an interview protocol was followed where in-depth interviews were conducted with them, and a total of 28 interviews were conducted with people who smoke, either with cigarette vendors or tobacco vendors who were selling loose cigarettes. So here are some pictures of the different kinds of these are those shops that had different kinds, those were selling different pretty big shops. Then there were small tobacco. It shows that my internet connection is unstable, so I stopped my video so that you.
Great, thank you.
And these are the small tobacco kiosks you'll easily find on. And they primarily sell cigarettes and BDs and some candies that go along with them. Okay, I'm not sure why I'm not able to move my slides forward. These are then I'll bring tobacco product. And these grocery store owners, items like food, milk, and wheat, flours, and other kinds of grocery items. And finally, street vendors, which you'll usually find in like prominent places like near to tourist destinations or any tourist place. You'll easily find these kinds of street vendors who move from one place to another. And finally, I interviewed policymakers and implementers and law enforcement officials. They are the stakeholders that are actually involved in policy implementations. And I interviewed a total of 26 policy implementers in both the cities, Delhi and Mumbai, and they belong to various departments and foundations and international foundations as well, like the Union, Vital Strategies, and WHO. So the implications for this, for conducting this research were like, it really helped me in identifying barriers to effective policy implementation of this policy. And I think it is also important to understand like such challenges because it helps in taking more informed decisions for improving implementation. And then it definitely helps in building capacity of implementers. Like sharing the lessons learned really helps better understand how to implement policies and programs successfully. Another implication is it also improves accountability because I'll be sharing these findings and will be able to tell whether the policy was actually implemented as intended. And most importantly, it provides evidence on like what works and what does not work in policy implementation and supports evidence-based policy making. So I would like to thank my study collaborators who have supported me in carrying out my fieldwork and providing support while I was in India. Joanna Cohen from IGTC, who sponsored my dissertation, and then Prakash Gupta and Mangesh Pednekar, who are at Healis, who have collaborated with us for conducting my data collection and who were really instrumental in connecting me with policymakers and implementers, especially those working in government settings because without Dr. Gupta and Dr. Pednekar, it would have been very challenging for me to reach out to government officials. So big thanks to them for their support. And here is just a picture of me with the Healis team. This was this was my last day in Mumbai when I went there to present my preliminary findings and share my data collection and fieldwork experience with their students and with them at their Healis office. So that was all from my side. Happy to answer questions.
Great, Mayank. Wonderful presentation. And thank you to you both. And little did our audience know that we'll get a little bit of policy implementation science a little bit with both of your work in doing that work in the global setting. So now is the time if you want to put questions in the chat. I'm going to start off with one and then I will open it up. I see there's one question already in the chat, or if you would like to get off of mute and also ask your questions for our two speakers, you're happy to do that. So I want to start first with something that's very important in implementation science. I saw that you alluded to it in both of your presentations, but the main focus that we think about in grounding our work is often context. You showed some of that with pictures and things like that, but what are the factors related to context that you consider, Dr. Hébert and Mayank, in your global cancer prevention and control work?
Yeah, I'll go ahead and start. One of the things that I think was an important driver of my work with Prakash was an understanding of where he was coming from a socio-religious perspective. He is a really devout Hindu. And I think it went particularly well because I met him at a time in my life when I was really open to other cultures. I remember, driving with my dad when I was a kid, and he would say things like, "I'm going to leave for parts unknown," and "What's on the other side of the hill?" And I just grew up with this idea, but I grew up relatively poor. We weren't affluent, and I didn't know what was over the next hill. So I was determined to figure it out, and it became a metaphor. I mean, it wasn't just literally what's over the next hill. Yeah, that's interesting, but just so when Prakash and I connected in the late 1980s, I was really open. I mean, I was a new father. My father was in the process of dying. I was having all these interesting experiences, and I was just open to him, and he was open to me, and we just loved interacting with each other, and we became deep friends. So I think that gets at the inner setting, outer setting part of the framework, I think. Not that I would have ever formulated it that way or talked about it that way, but I think that's what was going on.
Great, thank you. And I think what you're saying is very true, is that all of us come a little bit, I think you're speaking about positionality in terms of his context and religion, and working with him was also a contextual factor too in some of the work and interactions that you all had. Mayank, what's your take on context? I know we saw a lot of pictures for both of you. We also understood the context that I thought was fascinating, that you could buy things singly, as you said, instead of like packs and things like that in India. What are your factors related to context that you considered in your work?
So before I speak, I'll just turn off my video because I'm seeing that my internet connection is unstable. Okay. So yeah, I just adding on to Dr. Hébert's points, I think that like context is really crucial in implementation science research, because it ultimately influences the success or like failure of your implementation effort. And the contextual factors that I considered for my project like included the like characteristics of the stakeholders organization with whom with whom I conducted interviews, like whether their organization prioritized tobacco control or not, whether tobacco control was a priority for them or whether other issues were priority for them, and then to assess attitudes of those multiple stakeholders, including smokers, vendors, and then policy implementers, because that really provided me with the evidence whether the policy will work or not, whether it's feasible to implement a policy in a country like India, where the tobacco market is highly unregulated, and whether there were adequate resources to carry out the policy implementation. So those were like some of the factors that I had considered, and understanding the context like really helped in identifying the factors that impacted the implementation success.
Great, thank you for that. And I really also admire the number of folks that you talk to, both in the community and policymakers, as you just alluded to, getting their insights. I just had the question because your work is so tied to policy implementation. Were you able to talk to folks that were pro like public health measures and also against them, or were those people who are not focus on, the public health policies, willing to talk to you?
So the stakeholders that I had a chance to speak with, they were in support of this policy, but yes, there were like implementation issues and enforcement related issues. For example, I had a chance to speak with one of a senior police official, and although he was in support of this policy, but what I got to learn from him was that they are not able to allocate sufficient time to this issue of tobacco control, because he was like, you tell me, what should I focus on? Should I focus on handling criminal cases, or should I focus on conducting like inspection visits to these tobacco vendors and see whether they are selling loose products or not? So yeah, so the stakeholders were in support of this policy, but yes, we have got to know that there are many implementation and enforcement related challenges that need to be dealt with for effectively implementing this policy.
Great, thank you for sharing that. We have some great questions from our scholars. So Bianca, I don't know if you want to ask your question. I'm happy to ask it for you as well.
Let me unmute for a little second. Apologies. Interest is whether you used a particular framework or maybe multiple frameworks that informed your work, your data collection, and your data analysis as part of this study, and whether you went into the sphere of political science with those choices that might be connected to framework selection.
Thanks for the question, Bianca. So yes, I did use a framework which was developed by Belaine and colleagues, and this framework was like focused on policy implementation research. And the reason why I used this framework was because this was already field tested in a low and middle income countries. So it like already involved the different contextual factors that I wanted to target through my data collection. For example, it involved assessing the like stakeholders' knowledge regarding policy implementation, and then knowledge was related to the level of interest. Like if they have more knowledge about this policy, they'll be more interested in implementing it. And then the level of interest was then related to their position. If they are interested in this, they will be more in a favorable position to implement it. And likewise, position was related with power. And like if they have sufficient power, if they have adequate resources with them, they will be in a better position to they'll be in a better position to favor this policy and implement this policy.
Okay, thank you. So the questions that you used during your interviews, they came all from that particular framework?
Yes, correct. Yes.
Okay, thank you.
Dan, you had a very nice perspective that we often think about undergirds a lot of our implementation science work. Do you want to ask your question, or would you like me to read it?
Hi everyone, I'm Jen Cruz. I'm a doctoral candidate at Harvard in the Department of Social and Behavioral Sciences. And so this has been very great. One, because I'm a card-carrying epidemiologist in a behavioral sciences department, and now know that it's very okay to never be a behavioral scientist, but still do the work. But I think a lot of stuff that I'm really focused on is health equity and health justice, and in the US. And as I've slowly made my way into implementation science, have seen that it's relatively new to talk about the role of structural racism. And the papers that are coming out that everyone's citing have come out in the past 2-3 years. And work that I had done previously, living and working in India, the role of caste had also been something that was very difficult to have conversations about. And I'm kind of seeing these parallels between coming into a new field that isn't, I mean, people will label critical, versus in a country where it is very difficult to have those conversations because it is deeply embedded, and naming it is not always easy. And so I'm wondering, in your work, and maybe on like a larger global perspective, like how do you see naming these things and bringing in the emphasis that like there are structural things of like who are selling tobacco, things like we saw a picture of a child. Why was that child? Was that related to a structural barrier or something that they don't have a choice? And so thinking about the policy implications, if you take those away, what other options and opportunities, and is it more harmful or is it more hurtful to folks? So I don't know if you have thoughts or perspectives of just on a global level, like what does it look like to do really critical work that names this, but also how does that impact our ability to actually achieve health equity and outside?
So I'd like to start this, but then kick it over to Mayank. So one of the way BDs are produced as a cottage industry, basically. They're made at home. The family is involved in doing this. So the kids are not just selling these products, the kids are making these products. So it is really pernicious. I mean, it's deeply embedded in all kinds of sociocultural problems. And you know, one of the underlying problems clearly has to do with access to means of production, with wealth disparities. In India, when I first went to India 40 some odd years ago, the United States was the most equitable country on earth. We had the lowest correlation between parental and child education, for example. We had a relatively even distribution of wealth. And now we're just as bad as India. So I guess it's sounding a little bit of a pessimistic note, but it's a mess. And the people who have been at the forefront of the civil rights movement here, and Gandhi, freedom movement in India, understood that very well. I mean, Gandhi's whole thing was, he didn't call them Dalits, but the Harijans. I mean, he was very, very interested in uplifting that part of society. But yes, the huge structural problems. And, so Mayank, you could talk a little bit more about that both from the perspective of the sale of these products and the production of these products and the use, by the way, all three things.
Well, just wanted to add on Dr. Hébert's point. That's what I was about to say, that I think poverty drives this. And as he mentioned, that the BD market is highly unregulated. It's mainly manufactured within a household setting where you'll find small children and women hand rolling these products inside their homes and then selling them into markets in rural as well as urban areas. And they basically earn their livelihood from this. And there have been talks whether this market should be regulated or not, like imposing higher taxes on BDs. But what happens then is that these manufacturers, these small BD manufacturers, and what they do is they take support from the tobacco industry. Tobacco industry plays number of tactics to, like overpass these provisions, and tobacco industry like supports these BD manufacturers, and then they rebel against such a policy. So it's very challenging. It's like really challenging to address these issues because they earn their livelihoods from like manufacturing BDs, from selling tobacco products. It's the poverty that drives these decisions.
So I'd like to throw something else out there, which is an interesting concept. Remember when I was giving my talk, I talked about how damaging tobacco is to the environment. It's a very heavy feeding crop. And the places in the world where you can grow tobacco successfully are also places in the world where you can grow medicinal herbs successfully. And the markup in cost of medicinal herbs to tobacco it's much higher. So one very clever way of dealing with this would be to change the agricultural production from tobacco and tambora leaves and things like that over to medicinal herbs. And India would be a great place to do this. And you see in South India, you know, there are getting to be a lot of specialized organic spice plantations and things like that. Now, there's concentrations of wealth there too, but it could be a clever way out of this, where at least you're producing things that are good for health, and there's some scope for, let's say, economic and social advancement at the same time. But I think we need to start thinking about conceiving of these things differently, you know, basically replacing tobacco with something else. So we think about the push, but there's also the pull, right? So, you know, people don't still use typewriters because people were told they couldn't use typewriters. They don't use typewriters because computers became so much better. So I think part of what we need to be doing on the public health side of things, and one of the reasons why I was motivated to start our company, is the way things work in the world is you got to make them commercially viable. And if you can do that and also support programs that lift people out of poverty, that's the key. Now, that's a fairly vague statement, but, you know, we could get more specific about what exactly to do there. But then you have to change price supports. You know, in this country, it's corn, 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 corn. In India, it's, you know, sugar and white rice, you know, on the food side of things. So you gotta change the incentive structure, but that should be dead easy to do if there's a political will.
Fascinating. We need to talk about public health entrepreneurship for that replacement, Dr. Hébert, in terms of not only thinking about interventions, but yes.
Yeah, oh, absolutely.
Yes, and capital, yes.
Yeah, we need to figure
investment
out
in
how
those
to,
areas.
unless we can figure out a way to make it economically viable, it won't work.
Well, I'm mindful of the time, so I want to thank both Dr. Hébert and Mayank for their presentation. Thank you for sharing your experiences. And Mayank, I'm not on your dissertation committee, but I would A+. Hopefully you will get closer to being done soon. We look forward to seeing everyone in Atlanta for the CPCRN annual meeting soon, May 24th to 26th. You'll be getting a lot more information about that from the coordinating center. And thank you all for a great presentation today, and also fielding questions from our audience as well. So have a great day, everyone.
Cheers.